makan nanti kesel. Gak pagi-pagi nih makan. Ini apa kabar? Jadi mute semua. Mulai lagi. Apa kabar? Nah, boleh cakap ya. Halo Pak Komedi, apa kabar? Tak boleh cakap ya. Halo, apa Pak Komedi, apa kabar nih? Nggak boleh cakap nih, kena mute semua nih. Hello, Miss Jaya sudah welcome you.
Afternoon to everyone.
Yeah, how are you?
You're fine, thank you, Dr. Reza.
Yeah.
Dr. Yu is here with us.
Yeah, we will. Yes, he will because I have to review of my WhatsApp to him. Because I say him, I know you with him. Therefore, you must be to coming. Yeah. You look this the Javanese head.
Okay, nice.
Javanese head.
So you are the man of the world.
I am a Chinese, but not Javanese. But I school in Java. This is no, Miss. This is the director of Pelni Nursing College, Miss Bunta Handayani. You can say hello.
Happy to see you, Miss Bunta.
Miss Muntar, very interesting to invite you direct to Jakarta next time after COVID pandemic. Go home.
Yeah, after COVID gets over, we all can meet directly.
Because Miss Bunta is very interesting to Hema Malini, ya. The style.
Amitabh Bachchan. Cahrukan. I like it.
Ya, Carukan boleh, tapi jangan Caru Reza ya. Saya tak sama.
Even few of my friends from Saudi Arabia, they too have joined here.
Yeah.
Dr. Premlata and Dr. Shanti and all, they have joined.
Dr. Shanti. Okay.
Sekarang tuan rumahnya Ibu Bunta, saya nggak boleh cakap banyak. How about COVID pandemic in your town?
Second wave has come. It is horrible now. Spreading fast to the people.
Okay. You have vaccine? Miss Jaya sudah, you have vaccine now? Injection vaccine.
Dr. Reza, can I be relieved at maybe my time after 1.5 hours because I have programmed.
Yeah, your sound is clear. It's good. Never mind. Your sound is clear. Mana music tadi? Ibu moderator sudah siap, betul ya? Good, good, good. Miss moderator is available. Good, good, good.
Yes, good afternoon.
Good afternoon, Ibu Ana atau Mbak Ana. Professor, you will be coming. I have to thank
Yeah,
you.
I'm here.
Wow,
Yeah, I'm here. How are you?
amazing. Ayam baik.
Yeah, baik.
Saya. Oke, Prof. Itu Dr. Ahmad sebagai presiden foundation, you can to say hello dengan Ibu Punta. You have to make
Halo, halo. Good afternoon semuanya. Good
Good
Pak Reza,
afternoon.
itu Pak Ahmad,
Halo,
Ketua
Pak
Yayasan.
Reja.
Ya, Pak
Dr.
Ahmad.
Yu,
Halo.
how are you doing?
Hello, Prof. Jaya.
How are you doing,
I'm
Dr.
fine.
Yu?
What are you
So
doing?
happy to see you and thank you for the
Yeah, I'm here.
opportunity.
Yeah, good, good, good. Bagus.
Rame nih, rame nih.
Very good. It's beautiful.
So after, I think after 2 years again I'm meeting you now virtually.
Yeah. Yes, true.
Yeah. I think we met 2 years
Okay.
back.
Mr.
Yeah,
Yu,
2 years back. Yes.
Mr. Yu, I
Very
guna
fine.
head dari Kedah ni. Ya ke?
Ya kak, you cakap Kedah. Oh, kau pakai yang Kedah.
Tak ada lah Jawa ni.
Ni Jawa ni.
Okay. Hey, you can to say hello to President Foundation, Mr. Ahmad Sadani.
How are you, Mr. Ahmad?
Halo, halo, halo.
Ini dekan dari Universitas AIDS,
Ya.
How are you, Prof?
I'm fine. I'm fine here.
I'm fine.
Uh,
Thank you, Prof.
How about Kedah COVID pandemic, Prof. You?
now it's coming down. Now the Kedah already become green, except
Oh,
my Kuala Muda. Kuala Muda is still under orange
oh, I see.
because there are some cases, some cluster around.
Yeah, I think
Especially near the hospital.
yeah, because the I'm nursing impact is good for the citizen, eh?
Yeah.
Yeah.
How is Indonesia? The pandemic, is it okay now?
Wow, this is the champion in the ASEAN.
Oh, champion, huh?
Orang
How
ramai
about
pening
there,
beratur.
Yeah.
Dr. Yu?
Yeah.
There it's okay for you all. How about pandemic?
Our place here now is already coming down to, they're coming down to 1,000 plus.
Okay.
Below 1,000. These few days going up again to 1,003, 1,004. If not, really go down to below 1,000. Then
Okay.
there's another cluster coming up, especially near the hospital side. So coming back again, 1,000 over. But so far so good. Our destination drive is carry on very fast.
Yeah. Prof, you yesterday we discussed about political Malaysia and Indonesia. Yesterday, you tahu tak? Pandemic is what the calling this is? I mean added to my Udin tak boleh buat fire you. Advantage to him.
Yalah.
Aduh. Tapi orang nursing tak interesting cakap politik lah.
Tadi pagi ada nursing orang ada bagi lecture Miss Kui ada.
Ya, itu di lain saya punya partnership. Itu sebab you bagi tahu saya sudah done dekat sana, jadi saya arrange yang baru lagi dekat sini.
Ya, okey.
Yang penting perintah Datuk you Datuk Sri you.
Datuk Sri.
Yeah, this has happened because of Dr. Yu.
Yeah, because of me.
I must really thank you.
Yeah. Okay. At least we know our friends, a lot of friends here. Next time we can do a MOU or networking with the Indonesian friends.
Mulai aja.
Ya,
Dr. Yu, have you started College of Nursing? BSc program?
Our bachelor program already started.
Okay.
About a year ago. About coming to the student coming to third year, final year.
Okay.
So it's 3.5 years.
Okay. We will start just now, Dr. Buntar.
Okay.
We will start.
Miss Ahmad.
Okay, I leave it to the organizer, please.
Yeah.
Okay, can you hear me, Mr. Reza?
Yes, please.
Yes, okay. Thank you for
You
honorable
you
for
you
me.
your son there are feedback you can to arrange, but clear now, please. Never mind.
Yes, okay. We will turn on the other speaker. Okay.
Yeah,
Okay. Is it clear, Mr. Reza?
clear.
Okay. Ladies and gentlemen, may I have your attention? Our share
Okay,
lecture
we
will
can.
start. So please turn off the speaker and open the camera. Thank you very much for preparing and attending our share lecture. I'm Susiana Johnson. You can call me Anna, nursing lecturer in nursing in P.S.G Academy of Nursing, Jakarta. I feel honored to be your moderator today. I'm very happy to see you in this Zoom meeting and welcome to all of you in this share lecture. The share lecture of today is about the Akademi missiles and pressure and basic management of obstetric emergencies. Okay, good afternoon all.
Good afternoon.
Yeah. In this moment, I would like to welcome the honorable guests, participants, students, and our respected from the Foundation Chairman of Yayasan Samudra Akta, Master of Public, Director of Nursing Academy of
Oh, there are problem of the ceremony and moderator. Oh, there are problem of sounds.
How about my
Okay, clear
how
now.
the clear?
Yeah,
Clear,
clear
okay.
now. Yeah.
Maybe in Jakarta is the day so bad, so the network is bad too. Okay, I will continue our opening. And next, the Honorable Respectable Director of ASEAN Lecture Community, Associate Professor Tuku Reza,
Yes, I am.
Dean IMS University Malaysia, Associate Professor Dr. Yuchewa,
Yes.
welcome. And the co-host Priyalinov, Master of Management,
Yep.
and of course, our presenter of this lecture, Professor Dr. Ajaya Suda, Master of Science, P.S.G, and was Nurse Putri Permatasari, Master in Nursing. Ladies and gentlemen, please give appreciation to all of us and especially to our speakers today. My beloved attendants, before the lecture starts, let me tell you how this meeting will go. This lecture is divided into 5 sessions. First, opening. 2, presentation. 3, discussion. 4, evaluation. And 5th, closing. Next is welcome speech from the Foundation President of Yayasan Samudra Akta. To all participants, please welcome Mr. Ahmad Samdani.
Thank you, Miss Anna. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore dan salam sejahtera untuk kita semua, terutama bagi mahasiswa dan mahasiswi Akper Rumah Sakit Pelni yang mengikuti acara ini. Good afternoon, ladies and gentlemen. Thank you to everyone for being here today as this Zoom meeting. I am Ahmad Samdani, President Director of Samudra Akta Foundation, Head of Pelni Academy of Nursing, Jakarta. Welcome to International Shared Lecture and University Collaboration of Pelni Academy of Nursing Jakarta with University College of Nursing Coimbatore, India. Before we start our agenda, I would like to express my appreciation to Associate Prof. Dr. Yu Chiwa as Dean IMS University Malaysia, Professor Dr. Ajaya Suda MSc P.H.D. RNRM as P.S.G. University's College of Nursing Coimbatore, India. Welcome to Teku Sahrul Reja, Director of ASEAN Lecture Community, Nurse Putri Permatasari, Magister of Nursing, a speaker from Pelni Nursing Academy of Jakarta, and all of you. In today's sharing lecture, we will learn about basic management of obstetric emergencies during antenatal, during the intrapartum and postnatal period, evidence-based and respectful intrapartum care. Hopefully that can increase our knowledge and helpful to all of us. Well, I will to hand over it to Nurse Susiana Johnson, Magister of Nursing Pediatric, our moderator today. I would like to say once more on behalf of this sharing lecture, welcome and my God blessing us. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon.
It's good. Short and meaningful.
Thank you, Mr. Ahmad. All attendants, in this lovely day, we have two speakers. First speaker is Nurse Putri Permatasari, Master
ini sambutan dari Prof. Yu dulu, mewakili AIM University.
Okay, I'm so sorry. Okay, next, welcome speech from AIMS University.
Prof. Yu.
Associate Prof. Dr. Yu Chehwa, please welcome.
Thank you, the MC, Puan Siti. Respected guests, audience, ladies and gentlemen, good day to everyone. Welcome to our International Share Lectures and University Collaboration webinar, organized by Indonesian Nursing Academy Association and Nandalah International Jakarta.
Yep.
I would like to thank the organizer, come host, especially Prof. Sharu and Mr. Linot for inviting me to this auspicious occasion to say a few words as an inception of today's webinar. The objective of today's event is to bring together the experts from our collaborative partners. There is the Pelni Nursing Academy Jakarta and P.S.G. University College of Nursing, Coimbatore, India, to share their idea and experience from their respective countries and culture with our audience today. In addition to this forum helps to strengthen our academic collaboration partnership and creating a useful network for research collaboration between the two parties. As the world is facing the unprecedented threat of the COVID-19 pandemic, university and college in the world are trying their best to adapt and adjust to the new norm of teaching and learning methods. Through this online platform, especially like you're using Zoom, it's helped to prevent us from limit our physical contact by adhering to our standard operating procedure as SOP, reduce unnecessary travel to break the chain of viral transmission. And at the same time, everyone is in learning and picking up a new methods, new skill by going online and learning management system. I can say that before that, we are in this type of an aging population. It's very difficult for us to go online last time. When we go to the traditional method of face-to-face. So suddenly we are because of this pandemic, we forced to use the online teaching methods. So we found that it is very useful and we can actually access, it's the same likewise for the student, they can access the learning materials through the learning management system. So technology already doing a lot during this critical period of the pandemic. At this juncture, I would like to thank the P.S.G. University and the Prof. Jaya Suda for consenting to deliver and share her expert field in obstetrics and gynecology with all. And of course, to our Miss Putri Permatasari on the field as well. So I leave the moderator to do the justice. On my part, on behalf of the MS University, I hope our international collaboration will grow and hope to see more collaboration on this kind in the near future. I hope our collaboration and willingness to share will create a synergy, the bonus that is achieved when the teams are work together harmoniously. And last, let us join hands together, as coming together is a beginning. Keeping together is a progress. Working together is a success. Lastly, I would like to wish everyone in this forum a very fruitful session today. Thank you. Thank you very much.
Thank you. Welcome. Very good.
Thank you. Thank you. Boleh faham ke?
Boleh faham.
Boleh faham. Dia cakap boleh faham. Jangan lahap kita.
Insyaallah.
Bagus.
Okay, thank you, Associate Professor Dr. Yu Chehwa. And then I will continue our main schedule today. So in this lovely day, we have two speakers. First speaker is Nurse Putri Permatasari, Master in Nursing, with the topic Dioketani, Massage and Pressure at the Acupressure Point GB21 on the production PF breast milk in post-session cesarean mother. Nurse Putri is a lecturer at Nursing Akademi of Jakarta. She holds a master degree in nursing at Muhammadiyah University of Jakarta, Indonesia. And then our second speaker today is Professor Dr. Ajaya Suda, Master of Science, P.S.G, with the topic Basic Management of Obstetric Emergency during antenatal, during the intrapartum and postnatal period, evidence-based and respectful intrapartum care. Professor Asudajaya is P.S.G University College of Nursing, Coimbatore, India. Now, allow me to welcome the first speaker, Nurse Putri. Please take your time.
Okay, thank you, Miss Anna. Thank you for the opportunity given to me. I am Putri Permatasari. I will present my research with the title The Effectiveness of Aketani Massage and Pressure at the Acupressure Point GB21 on breast milk production in post-sexual cesarean mother. Okay, my talk will be in 5 parts. I am going to divide in the first part background, then in the second part purposes, then in third part results, then in fourth part conclusion, then in fifth part suggestion. My talk will take about around 15 minutes. Okay, next. This is data according to WHO in 2020. Globally, in 2019, 144 million children under 5 were estimated to be stunted to short for age. 47 million were estimated to be wasted to thin for age. And 38.3 million were overweight or obese. And only about 44% of infant age 0 to 6 months worldwide were exclusively breastfed over the period of 2015 to 2020. WHO and UNICEF recommend early initiation of breastfeeding within 1 hour of birth, exclusive breastfeeding for the first 6 months of life, and introduction of nutritionally adequate and safe complementary solid food at 6 months together with continued breastfeeding up to 2 years of age or beyond. The plan includes 6 targets, of which is to increase by 2025 the rate of exclusive breastfeeding for the first 6 months up to at least 50%. Okay, next. According to data in the year 2017, neonatal mortality rate 15 per 1,000 and infant mortality rate 24 per 1,000. And goals and objective Indonesian Ministry of Health 2024, neonatal mortality rate 10 per 1,000 and infant mortality rate 16 per 1,000. And target global SDGs 2030, 7 per 1,000 and infant mortality rate 12 per 1,000. Okay, next. The benefits of breastfeeding are divided into 2, for mothers and babies for breastfeeding. Mothers, it can help in natural contraception. Breastfeeding delays the mother's menstrual period so that it can help the mother to naturally spacing her pregnancies. This is called lactational amenorrhea. And practical and economical. By providing exclusive breastfeeding, it can help reduce the cost of buying formula milk. It is also at a natural temperature and is free of bacteria. So there is no need to be heat and sterile. Is bonding attachment. By breastfeeding, it can provide more time for the mother to interact with the baby more often so that there is bonding. And is protect mother's health, helping the early involution of the uterus during postpartum, so as to prevent postpartum hemorrhage. When breastfeeding in the baby will stimulate the hormone oxytocin, so that oxytocin help contraction in the uterus, thus preventing postpartum bleeding. Breastfeeding also helps prevent breast cancer risks. This is because when breastfeeding, the hormone estrogen decreases, while without breastfeeding activity, the hormone estrogen remains high, so this trigger breast cancer because there is no balance of the hormone estrogen and progesterone. Breastfeeding can help reduce the mother's weight because during pregnancy, there is a lot of fat under the skin. So this fat will be used for breastfeeding. And then for the baby, breast milk is source of nutrition. The first natural food for babies, breast supplies all the energy and nutritional needs that babies need during their growth and development. And is boosts the baby's immune system. Breast milk is very useful as an antibody. Antibody substances are substances that can form the immune system so that the baby becomes stronger and is able to reduce the risk of being attacked by virus and bacteria, help in baby growth and development. As helping baby grow, helping sensory and cognitive development in infant, such as increasing baby intelligence. According to experts, The fat contained in breast milk can increase the IQ of a child. Okay, next. And then there are the step-by-step Akademi message. Akademi message is designed by Sotonomi Akademi from Japan, certified as Akademi lactation management expert. Akademi message refers to a type of message in which there are 8 techniques, namely 7 retromammary space separation techniques and 1 milking technique for each area on the left and right breast switch are carried out for 15 to 20 minutes. Akademi method is a method of breast care that doesn't cause pain. Akademi method can stimulate the strength of the pectoralis muscle to increase milk production and make the breast softer and more elastic, making it easier for babies to suck breast milk. Akademi massage will also increase the feeling of comfort, improve the quality of breast milk, prevent nipple blister and breast engorgement, and can improve lactation problems. And next, the benefit of Akademi massage are reduce breast pain, increase milk supply, resolution for blocked breast duct, swelling, and mastitis. Stimulate prolactin and oxytocin. Next. As you can see, there are the point pressure GB21. Pressure at acupressure point GB21. Acupressure is a type of traditional Chinese therapy that is based on pressure on specific acupoint in the body, which leads to energy balance in the body. The patient is in sitting position and nurse in a position as comfortable as possible. Determine the location of the GB21 point that will be performed acupressure. GB21 point locates and the shoulder strength below the ear between the 2 muscles of halfway between the bulge of the neck bone, cervical 7, and the base of the upper arm. Apply olive oil on the point that will be massaged. Perform massage on the acupressure point for 20 to 40 seconds. 4 to 5 times for 5 minutes, around 5 minutes. Okay, next. And benefit of acupressure point GB21, maximizing the action of the hormone prolactin, stimulation of oxytocin hormone, reduce pain, increase a feeling of relaxation, calm and comfort, and reduce stress. Next. Purposes, the effectiveness of Akademi massage and pressure at GB21 acupressure point on breast milk production in post-cesarean mother. Next. This is a concept image from the research concept framework. Characteristic of post-sexual cesarean mothers: first, egg; second, education; third, religion; fourth, profession; 5, tribes. The end result, intervention of Akademi massage, breast milk production increases in indicator of mother and baby. In group A, women with post-sexual cesarean. And intervention pressure at acupressure point GB21 The end result, breast milk production increased in indicator of mother and baby in group B, women with post-sexual cesarean. Next, hypothesis is zero breast milk production increase in indicator of mothers and babies. There is no effect of the effectiveness of Akademi massage in group A and pressure at GB21 acupressure point in group B, 1 milk production in post-cesarean mothers group B. At alpha, there was an effect of the effectiveness of the Akademi massage in group A and pressure at the acupressure point GB21 in group B on milk production in post-cesarean section mothers. And next, so the result I did was pre and post on the first day. During pre, I made observation of breast milk production in post-sexual cesarean mothers using the mother's observation sheet and the baby's observation sheet. Then I did the Akademi massage intervention for 3 days, 2 times a day, morning and evening. Then on the fourth day, I did a pause, namely by measuring the production of again using the observation sheet of mothers and babies, like this for acupressure point GB21. Okay, next. 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 And then result. Based on the 2 intervention, it can be conclude that the Akademi massage intervention has the largest difference from the pressure intervention at the acupressure point GB21. So that the Akademi massage intervention has more influence on breast milk production than the indicator of mother in post-sexual cesarean mothers. And next. Next. Okay, result. Based on the result of the study, there was a difference in the effectiveness of massage and pressure group at the acupressure point GB21, milk production in post-sexual cesarean mothers from the indicator of mothers, and for infant indicators, there was no difference in effectiveness between Akademi massage and pressure at the acupressure point GB21. And next, conclusion. Conclusion, the majority of respondents were age 21 to 35 years, was 34 people. This is because mother age 21 to 35 years are mature and ready physically and socially to face pregnancy and childbirth. And next, suggestion. Nurse provide health education about non-pharmacological therapy by teaching and motivating patients and families to take Akademi massage and pressure at the acupressure point GB21, increasing milk production in post-sexual cesarean mothers with standard procedure that have been established as integral part of the nursing process. Non-pharmacological therapy of the Akademi massage and pressure at the acupressure point of GB21 on milk production in post-sexual cesarean mothers can be applied in the family center maternity care model approach. Okay, thank you.
Thank you. Nice presentation. Bagus.
Right, such an informative and interesting topic. Thank you to Nurse Putri. And then to all attendants, if you have any question to Nurse Putri, you may ask your question using Zoom chat, and don't forget to also write down your name along with your institution name. So next, ladies and gentlemen, now it's the time for the second presenting. Allow me to welcome our special speaker, Professor Ajaya Suda. Please take your time.
Thank you, Anna. Very good afternoon to everyone. I thank Ms. Reza, Dr. Yu for having given this opportunity, and Ms. Bunta and the organizing team. It's a well organized, and we are so happy to collaborate with you. My hearty congratulations on choosing the theme and having webinar on this day. It's a World Health Day. So we have started with the collaboration with 2 countries, including Malaysia, 3 countries. Now we may be collaborating with all the countries in the world, inshallah. So let me share, like, my presentation will be for 40 minutes and I'll leave it to you all open for the question and answer for 10 minutes. And today I'm going to deal about the obstetric emergency, because we knew it's a very vast topic, and do the presentation. And to start with that, I would like to say that, remember the last year, 2020, WHO has announced it's a year of the nurse midwives, because we are the one who help us live in a happy and healthier world. So let's take a minute to say thank you to all the nurses and midwives in this world who has done a great job during this pandemic from 2020 till now. So that's a theme for the last year. And this year we have is a World Health Day today. Let's build a fairer and healthier world for everyone. That's the reason I think Pelni College, who is having a hospital of more than 100 years, have started this collaboration to build a fairer and healthier world, not only for their country, throughout the world. I must really thank you and congratulate you for taking this event. Thank you all so much. As we knew that pregnancy, becoming a mother, it's a beautiful journey in every woman's life. It's a fruitful experience. And during this time, some women may experience some problem. That's what. So when we say obstetrical emergency, emergency means when there is it's a serious situation or occurrence which happens unexpectedly and demands immediately we need to do the action. So obstetric emergencies are the health problems which is going to be life-threatening for the mother as well as for the baby. So this may arise at any time during antenatal, that is during pregnancy, during labor or intrapartum, and after the delivery. So what is this maternal mortality ratio when we say that it's scaled in 2018? How many deaths MMR has happened in the whole world? We can see how it is going on in the country. So in our India, it is falling. Like when we see in 2004 and 2006, it was 254. And 16, it is 130. And 18, it is 112. Again, we are decreasing the number of maternal mortality ratio with the many programs. So this is our ratio in 2018. We have achieved to 112. We have achieved 113. From 120 again, we have reduced the number of this one. The best 5 states in India which has less mortality rate is Kerala, Maharashtra, Delhi, Tamil Nadu and Punjab. So we are in Tamil Nadu. So in India, when we say Kerala is the one which has decreased, a lot of maternal mortality incidence has become very low. You can see how the ratio has been decreased in Kerala and as well as in India. So in Chennai, that is the capital of our Tamil Nadu, here we find that maternal mortality is little increasing with the number of live births because of the many causes. And the most common cause which we identify is the hypertensive disorder. We thought it may be a hemorrhage or diabetic, but again now we found that hypertensive disorder is the most common cause for the maternal mortality and the morbidity. So, and now due to the COVID-19, we found that there is an increase in the maternal deaths due to COVID-19 in the year 2020. It is the overall global 14 countries, including Indonesia, where we have Bangladesh, Bhutan, Cambodia, India, Indonesia, Myanmar, Nepal, Pakistan, all 14 countries. When we see that, best case scenarios based on that, maternal death is the same. But due to COVID, if you say the additional deaths is increased during the COVID-19, it has become from 94,603 to it has become 1,37,532. Due to the COVID-19, it has been increasing in rate. So what are the common causes of maternal deaths in our country? You see that, as I said, 37% counts for the hemorrhage, sepsis is 11%, hypertensive disorder and obstructed labor and any complication of abortion, any other medical disorders. So what are these obstetrical emergencies? During antepartum, that is during pregnancy. Because I said it's a very vast, I'll let you know what it is. So in emergency during antepartum, we have a condition called abortion, ectopic pregnancy, placenta previa, placental abruption, pre-eclampsia and eclampsia. Abortion, we knew that when the fetus is not remaining in mother's womb before 20 weeks of gestation, we call it as an abortion. Ectopic is when the fetus has been implanted other than the utero. And placenta previa and abruption placenta are the antepartum hemorrhagic disorders, and preeclampsia and eclampsia are the hypertensive disorders during pregnancy. So as we knew that abortion, it's a murder of an unborn baby or a child, we can say that, because when the mother goes in for the spontaneous abortion, we can say that it is a termination of pregnancy. And abortion can be intentional killing of a fetus to end a pregnancy. There are three ways, different people differ in many ways. So ultimately, the baby will be lost, cannot continue the pregnancy. So there may be different types of abortion. We have a spontaneous and induced. Spontaneous, when the mother becomes any of the medical disorders or anything, where she has isolated only once or recurrent abortion. Induced means for the legal and illegal. Illegal means we knew that through because of the criminal one, and this one the mother may undergo for it, and which may lead in for the septic. That is what is one of the cause for the maternal mortality also. That's the reason even we have legalized with the MTP, medical termination of pregnancy. So we encourage the mother to go with the MTP, not illegal abortion. So in that we have a different types. The spontaneous is threatened, where the baby can survive. Inevitable, we cannot. Complete, incomplete, missed, septic abortion, where the woman cannot continue her pregnancy except in case of threatened abortion. So these are the few one which I've told you: missed abortion, threatened, inevitable, incomplete, and complete. There are the few with the symptoms I've told you. And as we knew that what is a threatened abortion, we know that pregnancy is complicated by vaginal bleeding before 20 weeks in absence of other explanations. The woman may come with the mild bleeding, mild pain, cervix is closed, and bimanually everything is fine. So here only treatment by our nurse midwives is reassure the mother, give her the rest, apply the progesterone if needed. If she is RH negative, give anti-D. So that as a mother to be on rest, she can continue her pregnancy. In inevitable and incomplete or complete abortions, where we need to do the termination of pregnancy. Missed abortion also it's the same. Septic abortion, again the mother may come with the fever, chills, lower abdomen pain, vaginal discharge. So here we start with the antibiotic and terminate the pregnancy. Recurrent abortion, we knew that if the mother has a miscarriage more than 3 times, but we feel that the mother cannot continue the pregnancy, then you have to be on the rule out for the genetic disorders also. Any systematic disorders, genetic chromosomal disorders, or any infectious disorders to be ruled out. So induced abortion, we knew that it can be intentional, whether she wants to go, criminal or elective. Abortion that is intentional for criminal or medical causes. We knew that as a paramedic, a healthcare professional, care must be given to the patient, and as usual, despite that whether it's ethics or religious beliefs, you should show that empathy and company to the person. You are in the business of saving people, not lecturing them. Please remember that. We need to be compassionate in caring the people. Legal abortion, as we knew that termination is performed by medical practitioners assisted in at least 25 MTP and degree in OBG by the MTP Act. It has been done at the place approved under the Government of India. Termination is done for the condition 7 within the gestation week prescribed by the Act. And the abortion has to be reported to the Director of Health Services of the state. And I think now recently the court says even up to 24 weeks, they can do the abortion. When induction of abortion is performed without any cause for any reasons other than saving the mother's life. So this is what is we have said 25 million unsafe abortions takes place each year worldwide. Even though we have an act, legal, everything, still we found that 25 million unsafe abortions are taking place each year in the worldwide. So that should be controlled. And the complications because of that, the woman may go for the hemorrhage, shock, sepsis, uterine perforation, cervical injury, thromboembolism, anesthetic and psychiatric problem also. And the later period, she may go have infertility. She may not conceive, even if she wants to conceive. Ectopic gestation is the most common. There is an increased risk of spontaneous abortion and reduced birth weight. So what are the treatment which we say that we always go for the emergency management of abortion complication, family planning and counseling services, linkage to a full range of reproductive health services and the community participation. So here the key message for us, please see that the woman takes a rest for a few days, especially if she feels tired. Change the pads every 4 to 6 hours and do not have sexual intercourse until the bleeding stops. Advised to practice a safe sex and use a condom if at risk of sex. Return to the health facility as advised or in case of any problem or concern to the mother should be taught. Also, we must teach her about the family planning. Choose your family planning method. After the abortion, the interval to the next pregnancy is at least 6 months. Next 6 months, she should not conceive. That should be taught to each woman after the abortion. So what we have to do before we do the termination of pregnancy, ask the woman why she wants to terminate the pregnancy, if not the medical reason. Seek the history of undergoing ultrasound for sex selection in women seeking second trimester abortion. Inform her that early abortion is safe. As the pregnancy period goes up, it's not safe to terminate the pregnancy. Inform that abortion is legalized up to 20 weeks and is available in the government health facilities. Provide the information on availability of all the abortion services. That's our role, being a nurse midwives. Create the awareness about the legality of abortion. Provide the information on signs and symptoms of early pregnancy. Confirm that pregnancy kit, which can be detected early. Provide confidential counseling for abortion care. Recognize the signs and symptoms of abortion complication. Perform the examination for digital evacuation. Provide medication as per the doctor's advice prescription, and post-procedure contraceptive counseling to be given to the woman and the family planning services with the counseling. So this is a safe abortion one where we should not delay it, give comprehensive abortion care, should be provided to all the beneficiaries. Medical abortion is more suitable as it limits access to the patient contact. It can be provided in peripheral facilities and requires only less contact. So reduce the number of visits for medical abortion are possible and safe by simple protocols. Reduce unnecessary tests. Have number of visits less. Follow up with the clinic. Provide telephonic consultation because now we are going in for more of virtual. During COVID-19, many of the women during pregnancy are being consulted only with the telelactation. Ectopic pregnancy, we knew that implantation of fertilized ovum outside of the uterus or other than the uterine cavity, so which may cause hemorrhage. Even the woman may go in for the hypovolemic shock and death. It is one of the emergency that should be diagnosed at the earliest and should be treated. It can be a medical management or surgical management. Medical management, the drug of choice is methotrexate to terminate the pregnancy. Or surgical management, we have to go in for the DNE. Dilatation and evacuation. So that is the management for the ectopic pregnancy. So next is the hemorrhagic disorders, that is abruptio placenta and placenta previa. I'm sure like every one of us knew that what is abruptio placenta and what is placenta previa. When it is being implanted in the low lying, that is placenta previa, where the placenta is been there in the upper uterine, the part that is premature separation of the placenta is called abruptio placenta. So as I said, placenta is implanted partially or completely over the lower uterine segment is called placenta previa. So as a nurse midwife, please remember that if the woman comes with a placenta previa, never try to do the vaginal examination. So there are different types of placenta previa, especially when she comes with the complete or this one, partial. We have marginal. According to the location of the placenta, we can divide it as a normal low plantation, partial and complete placenta previa. So what are the symptoms the woman may have? That's what I have given you the thing, previa. That means painless vaginal bright red bleeding, relaxed soft uterus, episodes of bleeding that is not spotting, visible bleeding is there, not concealed. Because in abruptio it will be a concealed, but here it is visible. And intercourse post bleeding also spontaneous and abnormal fetal position, either breech or transverse. So this is the signs and symptoms of pneumonic, what we mean it as a previa. So woman may come with the painless vaginal bleeding with a premature contraction. Baby may be in the malposition breech or transverse, and uterus can be larger than the normal. So what we should do, if it is a grade 1 and 2, deliver normally. If it is grade 3 and 4, that is if it is partial or the complete placenta previa lying in the lower of the uterus, then we have to go in for the cesarean section. And placental abruption, we know that premature separation of the placenta. So where the woman may come with bleeding, which can be a emergency, which can cause again cerebral palsy, any other injuries for the baby and the woman. It can be a revealed, concealed or mixed. But in placenta previa, we said it's a fresh bleeding, but here it can be a revealed or concealed, this one. So the separation again can be a marginal, partial or complete separation of the placenta. So clinically, we can say that again women may come with the pain and signs of infection may be present. So the mother have fetal distress, PPH, postpartum hemorrhage, there is a chance. Covillary uterus, Sihan syndrome, these are the complications the woman may go in for it, puerperal sepsis after the treatment. So what we should do, monitor the vital signs, assess the vaginal bleeding, pain and the fundal height, give her the bed rest, administer the oxygen, IV fluid and blood products, monitor and treat for the hypovolemia. That's most important. We fail to do that. Fluid volume deficit should not go in for it. We have to maintain the fluid and electrolyte balance so that the woman will not go in for the hypovolemic shock. Induce the vaginal delivery if mild separation is there. If moderate to severe, please take the woman for the cesarean delivery. Like hypertensive disorders, we have preeclampsia and eclampsia. We knew that preeclampsia is a multi-system disorder. It is development of the hypertension to the extent of more than 140/90 or more with the proteinuria induced by pregnancy after 20th week of gestation. So that is the International Society for Study of Hypertension in Pregnancy. So what is it preeclampsia? As I told you, high blood pressure can happen to any pregnant woman during the second. What is the risk to the mother, to the baby? Mother can go for seizure, stroke, organ damage and death. For the baby, there is chance for premature birth and death. What are the signs of preeclampsia? The woman may have pain, headache, feeling of nausea, throwing it up, seeing spots before the eyes. She can see the spots, and swelling in the feet, ankle, face, hands, everything. And she gains more than 5 pounds or 2 kg in a week. So if any of these symptoms, warning signs, please tell the woman to come to the health checkup immediately. So what should we do? Call the doctor, the midwife immediately, find out and please refer to the tertiary care facilities. If not been treated, we say that there is a chance for the woman to go for the HELLP syndrome. What is HELLP syndrome? Hemolysis, elevated liver enzyme, low platelet count. So that may be the one. So please remember that the hypertension can be of any types. It can be gestational or preeclampsia. Preeclampsia imposed with chronic hypertension. The woman would have had hypertension during pregnancy, she develops it. Eclampsia is along with the hypertension. If you don't treat it, the mother may go in with the convulsion and chronic hypertension with the pregnancy. So these are the symptoms which I have told you should be identified and should be treated immediately. If not, the mother may go in for the mortality. So what we should do? Screen the woman, try to manage it. Ultimate goal is to deliver, assess the gestational age, cervix, fetal well-being, and rule out the disease. Eclampsia is the most emergency condition because the woman with the hypertension, she will have a convulsion or coma. So that should be treated because in developed countries, 1 in 200 deliveries, the mother will have eclampsia. In developing countries, and 1 in 100 deliveries. So it can be prevented only by managing pre-eclampsia. So these are the signs and symptoms. These are the theoretical one. Maternal and fetal complications, what will be there? So try to avoid injury. That's most important, being a nurse midwife. Maintain the oxygenation for the mother. Minimize the risk of aspiration. And max sulfate is the drug of choice for the prevention of the eclampsia. The other emergencies during the labor, there is chance for cord prolapse, vasa previa, shoulder dystocia, placenta accreta, rupture of uterus, inversion of uterus, amniotic fluid embolism, and obstetrical shock. These are the emergencies during labor. Again, I'm not going to deal in detail about each condition because we have learned about it, how the cord prolapse occurs, and what is it, the management is going to be done. Discontinue the vaginal examination to reduce the risk of rupturing the membrane. Call and inform the obstetrician immediately. Monitor the fetal heart rate and the fetal well-being. And please tell the mother not to push when there is a cord prolapse. This is a position we keep the woman during the cord prolapse. We call it as a knee chest position or exaggerated Sims position to minimize the cord compression. And the bladder should be emptied. That is most important. Administer the oxygen. Obstetrical management, if cord pulsation is felt based on cervical dilatation, go in for the emergency cesarean immediately. If no, allow the labor to progress normally. This is a vasa previa, like insertion of the cord, how it's been inserted. This is also one of the emergency. We manage it with the elective cesarean. If it's a preterm, steroid for lung maturity is being given. And shoulder dystocia, again, this is most common even when the woman is diabetic. The macrosomic baby also, that's most common, the shoulder dystocia. Because it is the impaction of the anterior fetal shoulder against the maternal pubic bone after delivery of the fetal head. So that is also one of the emergency should be taken care. It can be because of the maternal obesity, fetal macrosomia, if the mother had previous shoulder dystocia or postpartum delivery. So what is this management for health? Again, there is acronym HELPER for shoulder. Call for the help, evaluate for the episiotomy. Maneuver is McRoberts maneuver for the legs, external pressure, suprapubic. Enter the rotational maneuvers, remove the posterior arm and roll the patient to her hands and knees. That is the one for the management of shoulder dystocia. So this is the maneuver which I told you. Legs flexed into the abdomen, rotation of the pelvis, alignment of the sacrum and opening of the birth canal. So where you apply the suprapubic pressure to the fetal anterior shoulder. This is a Rubin technique. It's also known as the reverse wood screw manner. It requires the practitioner to apply pressure on the posterior surface of the posterior shoulder. So you need an experienced person to do this procedure. The other one is rolling over to all four position, Gaskin maneuver, which is going to increase the pelvic dimension so that the fetal position can be shifted and which may free the impacted shoulder. The other maneuver is Zavanelli maneuver. That can be of replacement by reversing the cardinal movements of the labor. Fetal head is rotated to occiput anterior position, flexed, rotated and pushed back up to the uterus. So then we have a placenta accreta. It is again an emergency condition which occurs when the placenta grows too deeply into the uterine wall. So there is chance for the invade the muscles of the uterus. When we come, it comes with the muscles of the uterus. That we call it as a placenta increta, or which may come through the uterine wall, that is placenta percreta. These both are the emergency one. So the management here is only hysterectomy immediately after delivery of the baby. So then we have the other threatening complication is uterus is turned outside partially or completely. That is a rupture of the uterus. Life-threatening complication in the third stage of labor. Incidence is 1 in 2000 deliveries. We have an inverted uterus, first degree, second degree, and third degree, prolapsed or inverted uterus. So why this occurs? That is because mismanagement of third stage of labor. If the woman has accreta or fundal implantation of placenta, there is a chance. The woman will come with abdominal pain, hemorrhage, sudden collapse, or she may go in for the shock, absence of uterine fundus, and there is a mass or outside the introitus. So 2 methods are there to manage the acute inversion. One is manual, which is called Johnson's method. The part of the uterus which is inverted last to be replaced. Okay. The other one is Sullivan's hydrostatic method, where the tube is passed into the posterior fornix, assistant closed vulva around the operator's wrist. Warm saline has been run until the pressure gradually restores the position of the uterus. So it is always prevention is better than cure. We say that whenever we want to deliver controlled contraction, avoid excessive traction, wait for the signs of placental separation, and please never ever give fundal pressure when deliver the baby. So the other one, uterine wall, anytime beyond 28 weeks of pregnancy, uterine scar rupture, can be of cesarean or previous operation, or any iatrogenic procedure, spontaneous obstetrical labor, or traumatic rupture. So in the pictorial, I've shown you how it affects. And it can be a complete, incomplete, or scar dehiscence. So rupture of uterus, previous scar, obstetrical labor. So only the management here is emergency laparotomy with blood transfusion, go for the hysterectomy, repair of rupture with the low parity. Next to the emergency is amniotic fluid embolism. It is a very rare cause of maternal collapse specific to pregnancy. But this also may go in for the cardiorespiratory compromise and severe DIC. So we should be careful to manage it if you identify the woman with the amniotic fluid embolism. Because time is the essence to save the life of the woman. And so whenever there is, the woman may come with a tachycardia, tachypnea, hypotension, hypothermia, and she will be drowsy and semi-conscious. So it should be maintained. So what we should do, we have to shout for the help. If airway is not patent, perform head tilt chin lift, jaw thrust, suction only if vomitus is present, place a mouth hug, give CPR, 30 chest compression with the 2 breaths, press sternum vertically. If the woman starts breathing, give oxygen 6 to 8 liters. And this is the management of shock. If the woman is atonic uterus, oxytocic and bimanual. Retained placenta is a manual removal. Infection means give the antibiotics. Retained products, manually remove that. Trauma means do the suturing and surgical repair. According to the cause, we are going to remove that. And during postpartum, it's postpartum hemorrhage. Because we knew when there is a blood loss, more than 500 ml during normal vaginal delivery and 1000 ml during cesarean section. Our blood, if the woman has more number of bloods or changes the pad more than 1 in every 5 minutes. So this is one of the, again, emergency, can be a primary or secondary PPH. So immediately what we should do, we should assess for the tone, trauma, tissue, or the thrombin. Delayed means look for the infection and retained placenta. So again, I told you hemorrhage is one of the cause. Hemorrhage, sepsis is one of the one. So hemorrhage is 27%. So what we should do to prevent it, ensure that birth preparedness and complications been reduced. Early identify the prolonged labor by partograph. Avoid unnecessary augmentation, fundal pressure or giving episiotomies. Control head delivery, perineal suturing. And please remember that the vitals are most important and check the completeness of the placenta. This is the one. You ask for the help, evaluate the vital signs, establish immediately 2 IV lines, catheterize the bladder, start the infusion immediately so that the woman will not go in for the hypovolemia. Give injection oxytocin, start with that 40 to 60 drops per minute, oxygen 6 to 8 liters, check whether the placenta has been expelled. If not, manage according to the cause of PPH. Vital signs, fluid intake output, bleeding heavily, rushing fluid, and raise the bed. Do not give woman anything to eat or drink. Keep the woman warm and covered. perform the bimanual compression in the uterus. This is at the subcenter level. How do we manage it? From there, we can transfer the woman to the thing. So what is our role here, being a nurse midwives? Assess the woman when we admit to the labor room, do the efficient vaginal examination, see the findings. Partograph is most important, CTG monitoring and its interpretation. We need to handle the emergency, must have a knowledge on oxytocin in labor, keep the observation skills. That is most important. So prompt documentation is most important. Emergency code, blue, team collaboration, participation in simulation emergency drills. And 7 rights of a childbearing woman I've told. The woman has a right to have information, get informed consent and refusal, respect, maintain the confidentiality, privacy of the woman, dignity, respect her, give her the equality, freedom from discrimination, equitable good. This is most important because ethics plays an important role now. Legal and ethics is most important. And she has a right to timely health care to the highest attainable level of health. And this is one article, different articles has come out, 7 rights of the childbearing woman. And this is just, I've given you all the example of case scenarios. Mrs. White, 33 years old, multigravid mother, got admitted in primary healthcare setting with 8 months of amenorrhea, appreciating the fetal movements well, was apparently normal 15 days back. But when she started noticing swelling of both lower limbs aggravated by work, there is no diurnal or postural variation present throughout the day, and history of headache, blurring of vision, bleeding per vagina. So on admission, her BP was 160/90. So what is this condition called? What is this condition called? Anyone? You can unmute and say. What are the warning signs we have seen in this case? Okay, it is a preeclampsia. Okay, so how did we manage this here? She has been managed in OPD basis, monitored the lab values. Her BP is 160/90, urine albumin was 2+, and fetal heart rate was 146 beats per minute, and she has been suggested to be on bed rest in a left lateral position. There was no sedatives or salt restriction and diuretics was given, and mother has been referred to the tertiary care hospital for further management. Okay, so next case scenario of intranatal period, a 28 years old woman with a history of previous cesarean section, admitted in labor ward at 38 weeks and 1 day of gestational age, complaints of abdominal pain, draining per vagina from previous day and night, and she had 2 episodes of vomiting, which was brownish in color. On general examination, she was conscious, oriented, whereas an abdominal examination shows that abdomen is longitudinally distended. Fetal parts have been felt superficially. While palpating, there is a diffuse tenderness. Auscultation, there was fetus is situated in the abdominal cavity towards the left. Uterus is retracted along with the placenta to the right side with hemoperitoneum and fetal bradycardia. So what do you think of this? This woman who came to the hospital, immediately because it's been an inversion of the uterus with a rupture, abdomen was opened by financial incision and hemoperitoneum is encountered. The uterus was completely ruptured. The slit was closed in layers, bilateral sterilization done and peritoneal toileting done. So mother received 1 unit of plasma, 1500 ml of lactate ringer, and more than 4 units of blood was been given to the mother. All the lab investigations came to normal range during and after the surgical exploration. So 2 hours after the surgery, she was being extubated in the recovery room and transferred to the postnatal ward for surveillance. And post-operatively, mother was conscious, uterus was well contracted, there was no soakage. She delivered a male baby with a weight of 3.08 kg. The baby was born with the Apgar score of 2/10 and 5/10 at 1 and 5 minutes. So baby has been intubated, shifted to the NICU, bladder was catheterized, umbilical artery catheter and umbilical vein catheter in situ after 2 days Weaning process started with CPAP mode and extubated. So urinary catheter and UVC was removed. After the condition of the mother and baby was stable, they were discharged from the hospital. So this is the way how we act immediately and save the life of the mother and the baby. The last scenario which I want to say during postnatal emergency. Mrs. X, 27-year-old preemie who got admitted in active labor at 38 plus 4 weeks had a spontaneous vaginal delivery with episiotomy. She delivered a female baby with a weight of 3.67 kg. Her delivery was not complicated. Mother had gushing of bright red color blood from the vagina, which measures about more than 500 ml. So what is this diagnosis? It's a postpartum hemorrhage. So how did we manage? All the obstetrician started with the large bore intravenous line, started oxytocin drip, dextrose drip, arranged for the blood transfusion, catheterized the bladder, fundal massage was done, elevated the foot end of the mother, fundal height was 17 centimeter, BP is 120/70, heart rate is 88, and the uterus was very soft and boggy. So what did we do? Again, oxytocin 10 units diluted with 500 ml of oral. Injection methogen was given. Injection syntocinon at 100 ml per hour as a maintenance dose. So because the mother was profusely bleeding from the genital tract, uterus feels firm after administration of the injection. So to conclude that, we, the nurse midwives, having a knowledge and proactive skills will help us to identify and manage the emergencies in an efficient way. So what we should do, A, B, C, D, E, not airway breathing circulation. This is act promptly, be alert to identify the onset, be familiar with the reason evidence-based technical skills, care with the concern, document accurately, execute emergency measures with competency. Please remember to end that to manage any obstetrical emergencies, all of us should follow A, B, C, D, E. That is most important. Because today is a World Health Day, 7th April 2021. When we as a nurse midwives, when we have love and skills to work together, expect a masterpiece. That's what the healthcare professionals aim for it every single day, to keep everyone happy and healthy. So hello world, we agree that health is a right, but it's not a privilege. So it's time to build a fairer, healthier world for everyone, everywhere. So once again, I thank the organizing team for having given this opportunity to present about obstetrical emergencies. I know it's very vast, so I've just put it in a gist for you all to understand with the case scenarios. And thank you so much once again for the opportunity. And I thank the listeners for the patience listening. Thank you all.
Thank you, Prof. Dr. Ajaya Suda. Informative and interesting presenting about geometry. And we have question in our chat Zoom. Do you have more time?
Yeah, I understand there is a question about spreads and salt can abort the myth. That's only the myth we have not. This was there in the olden days, and it's nowadays we are not practicing. It's not proved.
All right. So first question came from Heni Zartina from Nursing Academy of Pelni, Jakarta. She asks about how to avoid preeclampsia.
Yes. See, preeclampsia is when there is any family history of hypertension, everything. It's not preventable, but we can prevent further complication. If there is a family history of hypertension, we should be careful. And if the mother has a mild preeclampsia, need to be treated immediately so that she will not go in further more complications of severe preeclampsia or eclampsia.
Yeah, all right. Thank you, Prof. Jaya Suda. To all students, any question? If you have any more question, you can raise your hand. Hello. Okay, maybe it's all the question from our student, Prof. Jaya Suda. Thank you for your time, and I would like to tell you about, I really like your Indian clothes. What's the name? Indian clothes?
Pardon? Indian?
I really like your Indian clothes.
Yeah, Indian clothes, because again, India is a very big country. We have different. South Indian, we have saris. Okay. North India, they use salwars. Only in the westerns, they use pant shirts and things. So in South, being a South Indian, this is Tamil Nadu is a South Indian, so we prefer to wear sari.
It's really pretty. I hope we will, from Pelni, Jakarta, we will visit you in India, right?
Yeah.
Okay, thank
Really
you
happy to see
for
you
your
all.
attending. Yes. Okay, thank you for your attending, and thank you for your informative material. If you any more question?
Yeah, I thank Buntar, you are a Dean of College of Nursing,
Yes.
and Mr. Reza,
Yes.
and the opportunity given by Dr. Yu also. And so happy to see you, Anna, being an MC Master of Ceremony. It was really a good job.
Yes. Thank you, Prof. Ajaya
Thank you.
Suda.
Thank you,
Prof.
Thank you,
Prof. You.
Thank you.
Dr. Yu, because of you, we are here.
Yeah. We
Oh,
hope to meet once the pandemic is over. I don't know
Prof.
when will be over.
Can we take a photo for a moment?
We
Can you
also
take our photo a moment, right? Okay, please go slide one. One, two, three, please.
So thank you. Shall I sign off?
Thank you.
Thank you, Dr. Yu. Nice to meet
Thank
you.
you. I see you. I'll catch up with you one day.
Yeah, sure.
One day
We will
maybe
meet.
in India, or you come to Malaysia, or maybe
Sure.
we go to Jakarta.
Yeah, please come to India also. Coimbatore, we are waiting.
Yeah. Thank you. Thank you.
Okay, doctor.
Thank you. Bye.
Miss Bunta, also please come visit India, Coimbatore. Dr.
Okay, next time.
Yeah.
Inshallah. Thank you, Prof.
Thank you so much.
Thank you.
So for Prof. Ajay Suda, if you have any schedule, you can refer from Zoom meeting. Thank you for your time, and see you again next time.
Thank you. Thank you.
Thank you.
We can leave?
Okay, thank you.
Thank you. Thank you.
Our agenda is discussion. If you have any more questions to Miss Putri, you can ask your hand, or you can ask your question in room chat. So our student, do you have any question? Maybe Selfie Agustina? My handsome student, Pawas? Do you have question, Pawas? Or no? The next question came from Amelia. Her question is, I want to ask Ms. Putri, if the mother has COVID-19, if she can give the breast milk to her child. Okay, please, Ms. Putri. So student, as you know, Ms. Putri is still Miss, not Mrs., right?
Okay, thank you, Amelia Rimadanti. Thank you for the question. In bahasa saja ya, bahasa Indonesia. Bagaimana pada Ibu ibu menyusui, apakah bisa memberikan ASI pada saat masa pandemi COVID-19. Nah, untuk pemberian ASI pada ibu yang terkena COVID-19 itu pada ibu untuk khusus ibu yang tidak memiliki gejala atau tidak menunjukkan gejala itu bisa diberikan dengan ASI perahan. Nah, untuk perahan ASI-nya juga itu dengan memperhatikan protap kesehatan dan protap yang sudah dianjurkan oleh pemerintah ya. Jadi dia untuk memerah ASI-nya itu dia menggunakan APD yang dianjurkan dari rumah sakit karena penelitian saat ini tentang COVID-19 penelitiannya itu masih pro dan kontra tentang penularan vertikal dari ibu menyusui ke bayi melalui ASI. Ada penelitian mengatakan bahwa itu bisa terjadi penularan, tapi sebagian penelitian mengatakan juga bahwa itu tidak ada penularan secara vertikal dari ibu dan bayi melalui ASI. Oke, terima kasih Amelia Rimadanti.
Thank you, Miss.
Okay, thanks to Nurse Putri. Any more question? Hello, any more? No? Mana kok nggak ada? Ada emang nggak ada kan? Oke, ada yang mau nanya in bahasa sama Bu Putri. Jadi Bu Putri itu masih Miss ya, not Mrs. Mrs. itu kan untuk woman yang sudah menikah. Nggak ada? Oke, kalau nggak ada, kita tutup. Thank you for your attending, thank you for your participation, and thank you for your question. As a moderator, I hope you will have any informative or you can increase your knowledge from this lecture. So, see you again. Untuk tingkat 2, jangan lupa besok latihan. Okay, alright.
Selamat Putri, sukses.
Atau mau foto dulu kali ya?
Foto dulu kali. Foto dulu nak.
Buka dong kameranya.
Bukanya Kak, buka kameranya. Ayo.
Ada gue nggak buka juga.
Good luck Bu Putri dan Bu Ana Jensennya.
Kok kamu nanya?
Bu Putri senyumnya.
Kamu suka gila.
Senyumnya mantap sampai.
Oke, foto.
Ya, ada pertanyaan. Ya, ada pertanyaan. Buka kameranya ya. Open your camera. Mau 5. Mana mau 5? Tiara. Teti, Ozato, ayo selfie, take a foto.
Nur Anissa, background-nya kok nggak ada Nur Anissa.
Ajeng Laru.
Sebentar, Anissa lagi PNKes kayaknya deh.
Baru selesai PNKes, Bu.
Hah?
PNKes?
Baru selesai PNKes.
Oh, udah join, Anissa. Oh, yuk.
Wanda.
Tuh Aldi Supri tuh.
Supri, mana anak-anak tampannya Miss Ana? Can you
Hello, Ana. How are you?
I'm fine. Thank you.
My name is Gilang Dwi Cahaya.
Gila, nyalain kameramu.
Enggak, Pak. Lagi ramai di kosan ini anak-anak. Lagi bahas dekor buat acara angkatan 24.
No excuse. Open kamera. Cepet.
Ya, Bu. Oke,